Hello and welcome back to Learn It from a Layman. I am Carl Christensen, joined tonight by Matt, Tim, and Ian for the first time. Welcome to the podcast.
Thank you very much, Carl. Good to be here.
Yeah. Ian, we've all given most other family members that have joined the podcast the option of not claiming relationship, but I'm not going to give you the option. I've already outed you. We are related. So,
but no one knows how.
And, exactly. We'll leave it ambiguous.
That they don't. Although my last name is also Christensen, so that might, I could be a brother. I could be your cousin.
Right.
Fourth cousins could have the same last name. Yeah.
Yeah.
And exactly. if this podcast goes poorly, the relationship will become further and further distant.
Yes. Good.
Yeah, we appreciate Ian coming on. Ian has so we often have my friend Johnny on. Ian, he's a medical doctor, but Ian has a specialty in ophthalmology, which I just learned how to say from Ian. There are a bunch of letters in that word that don't seem to belong, but we can revisit that later. So Ian, have you finished residency? Are you in practice now?
I'm in my final year of residency at the University of Southern California, Roski Eye Institute. So I guess I can. You want me to introduce myself now?
Please do. Yes.
Sure. Well, I mean, I went to Brigham Young University for undergraduate, and then went to medical school at the University of Utah, and then came out here to LA. Honestly, there's not much more to be said, but my dad was here on the podcast, and let me just say I'm pretty shocked that you didn't invite me earlier. I obviously I must have too much expertise to be considered a true layman, and that's why you were so reluctant to invite me on.
Yes, and that's why
we got of our fans when they don't get invited on here. It's too expert.
I don't think Ian counts as a fan.
You were intimidated. You're intimidated by me. Yeah, which is that's why people don't get dates and that kind of thing. So,
well, I don't actually think we have fans either, but whatever.
What is
we
your
have a fan though?
Yeah, you're a fan. What is your other friend? What is his specialty?
Pediatrics.
Organization. Oh, okay. Nice. So he's a real doctor. And I am an eye dentist, which is sort of somewhat derogatory way that we get referred to. But in fact, that's only by other doctors who wish that they could be ophthalmologists. Because,
that's right.
You may hear that there's no perfect specialty, but that's actually incorrect. Ophthalmology is the best specialty. So yeah, we specialize in diseases and surgery of the eye. So diagnosing, treating disease of the eye. We do prescribe glasses as well, but that's more the purview of optometry.
Okay. And I have a whole list of questions for you, Ian. So I'm gonna hit you with a few of these very randomly generated by the thoughts of that come late at night to me. So you already started telling us a little bit about ophthalmology and optometry. So the difference between optometrist and there's another type of eye doctor too, isn't there?
There's a few different terms. There's opticians, and they make glasses, and then there's like orthoptists, and they're like kind of like NPs or PAs for ophthalmologists, and they do they depending on the practice setting, they do various things in the clinic. And then, but yeah, the two main eye care providers are optometry and ophthalmology.
And do you at what point do you specialize in ophthalmology versus is that just in residency where you start splitting out from more general medicine? Is that earlier in medical school?
No, yeah, exactly. So optometry is distinct from medicine because they, once they finish their bachelor degree, they go to optometry school, kind of like dental school. Okay. So they have 4-year optometry school, which is completely separate from medical school. And then ophthalmology is a subspecialty of medicine. So our specialty of medicine in that you go to 4 years of medical school after university, and then you can choose to go into ophthalmology. Ophthalmology is a pretty small field. Each year, I think there's about 468 or so slots in the country. So there's only at any one time, and it's 4-year residency. So at any one time, there's around 2,000 ophthalmology residents in the U.S. And then in terms of numbers of actual practicing ophthalmologists in the U.S., something around 20,000. But yeah, you go to medical school, you learn all the same stuff everyone else does, and then you forget 95% of it and focus on one organ.
Right.
Which sounds like a waste, but it's kind of nice.
If I remember correctly, Ian, your first year of residency, you didn't get to do anything related to the eye. It was the first year of the COVID pandemic, and you were out there doing actual doctor things, right?
Unfortunately, yes. Everyone has to do an intern year, and so internship is relatively distinct, and it's it's meant to kind of give you a solid foundation of medicine, I guess, but with potentially the side benefit to the hospital of having low cost labor on the wards to put in orders and manage patients on the floor. So not the actual floor, but the medicine floor. So yeah, I was at White Memorial Medical Center, which is just down the street from USC, and did a year during COVID in ICU and on the wards. And I can't say it was super relevant to what I'm doing now, but it was an experience for sure.
Right. Well, I'm sure that was you were very useful at the time, and good job for being a doctor and then forgetting all of that and just treating people's eyes.
Yes, thank you. Well, I was a healthcare hero, and now I'm just an eye dentist. So there you go.
Good. Well, your specialty, like you said, it's a very cushy job as far as doctors go, is my understanding, is you don't have to deal with the late night calls. I mean, literally, you do less work than Tim. Is that correct?
Wow, tell that to my residency director. I'd really appreciate if they heard that that's what's supposed to be happening.
I will.
I hope very much to be doing less work than Tim someday. I don't know how much Tim works, but it's probably too much, and
very little.
I would rather do less than he.
Doesn't he get like 3 months off in the summer where he doesn't have to do anything?
I do just try to think of the summertime and ignore everything else, and then I'm doing pretty good.
Yeah. Well, no. Well, during residency, my University of Southern California, we have a partnership with LA County Hospital, which is recently rebranded to LA General Hospital for some reason, but whatever. And it's one of the bigger hospitals here, safety net hospitals in Los Angeles. And so we're like the primary care eye providers for millions and millions of people here. And, they come into the emergency room at all hours, and nobody really knows what to do with the eyeballs, because I think we spend if you have an eye curriculum at all during medical school, it's like maybe a couple days to a week.
Oh, wow.
And so the emergency room physicians are uncomfortable, shall we say, in looking at and dealing with the disease of the eye. So, our first year, we take primary call at LA County, and it's pretty awful. We take it once a week, 24-hour call, and they just call us all day and all night, and it's pretty relentless, and you have to see all the consults, and it's pretty high acuity too. Once you're in private practice and you're just seeing your patients, you're like, you got your dry eyes, some cataracts, just like, routine stuff. But at County, we have just all the most ridiculous eye pathology you can imagine, or stuff you can't even imagine. I showed up my first day having no experience and taking call the very first week for 24 hours. And we have backup call. I'm backup now for some of the first year residents as a senior resident, they obviously came in and helped us out a lot, but there were terms, we use a lot of acronyms, and there's a lot of new stuff, and there were terms that I'd never heard before, and was having, and part of the exam is hard. You have to look at the eye through. We use a microscope. We use a slit lamp microscope, and we use what's called an indirect ophthalmoscope, and specialized lenses to look at the retina, and just like getting everything lined up and being able to really examine the eye is a challenge in and of itself. And so having to do that and then treat these complex conditions at the same time is pretty awful for the whole year, honestly, because it's just anyway. I just wish that Tim could experience it so he could stop talking trash about my job.
I'm sorry, but we gotta lash out at someone. We're educators. We're a bitter bunch. And
true. Well, you should come to my workplace then, and you can find out just how bitter you can get.
We just have settled on eye dentists as an easy patsy to slap on.
And it seems the best comparison to public education is a medical doctor, ophthalmologist. I mean, those are like the very, very similar pay scales and job requirements. So
yeah,
very true, very true.
Now, Ian, a serious question. Tell us one, like the craziest or most unusual scenario that you experienced during your time working there in the emergency room.
Let's see. I think it's kind of tough to really relay some of this stuff because it's so it's kind of rarefied. But there was one experience I remember in particular. There was a woman who came in who had she lost a lot of vision in both eyes. I think she was something like, once you go from 20/20 vision, right, you can see at 20 feet what the average person can see at 20 feet. And that's considered good vision, right? So, and then there's like a bell curve, and when you're dropping off of it, and you go to 20/40, 20/60, 20/80, 2100. And then once you can't see 2400, then we start seeing your count fingers vision. And then after count fingers vision, your hand motion vision. And then if you can't see the motion of the hand, then your light perception. And then after that, your no light perception. So true blindness is no light perception. So this lady was around count fingers vision, and she, was kind of didn't really know what was going on, and wanted us to figure out. And looked in the back of the eye. There's a lot of inflammation, and I decided to get her tested for syphilis. And we send a lot of tests when there's inflammation in the eye, which was positive. And so I had her come back, and I told her that, she had a syphilis infection, which when it involves the eye is essentially neurosyphilis. We consider it to have involved the brain as well. So you have to treat that with 2 weeks of IV antibiotics. And she leaned in and was like, she said, could this be related to 5G? And because with all the stuff going on out there, and I was like, I can't. I said, I can't rule it out. I can't rule it out. That's just one experience, but we deal with all kinds of crazy stuff. I mean, all the other stuff. It's just it's the volume. I think that's really really the difficult part of this training. So.
Okay, so we just got it from an ophthalmologist that 5G is going to affect our vision, right?
Right, 5G.
That's right. It's a conspiracy.
Yeah, exactly. It's all interrelated. You heard it here first, folks.
All right. We just broke some news on Learn It from a Layman.
That's right.
That's right. Scoop.
So
they're not talking about this on the mainstream media, guys.
Yeah.
You got to get
hushing it up.
I feel like we should actually put a disclaimer. Do not be the kind of person that believes this kind of stuff.
If you are, then you are the type of person who may just have a syphilitic eye infection.
It does make life, more interesting. But
Definitely.
yes. So going from the 5G syphilis story, let's go to a little bit more of the layman understanding of eyes, which is much worse than you said that your normal doctors in the emergency room are afraid to treat the eyes. I think most laymen are completely in the dark. See what I did there?
Or rather, maybe they're blind to the intricacies.
Okay. All right. I like it. Can you tell us? Okay, so the layman knows there's different parts of the eye. I think the layman knows that there's a retina. That's about as far as the layman might go. Can you tell us the different parts of the eye and kind of what their function is?
Sure. So at the very front of the eye, you have the cornea, right? So the cornea is the clear part of the eye that you can see through. Behind the cornea has 5 layers. I won't get into too much detail here, but that if you really wanted to, we could talk, the 5 layers of the cornea. But behind the cornea, you have what we call the anterior chamber of the eye, and that's full of aqueous humor, this fluid inside the eye. And then you have the iris, which is obviously the colored part of the eye, and then there's an aperture in the middle. That's the pupil. Behind the pupil, you have the lens, and so the lens sits behind the iris, and it's clear. You can't really see it. You look under the microscope, and behind that you have a big cavity, and that's the posterior segment of the eye, and that's full of vitreous humor, which is kind of like a jelly substance, kind of like a proteinaceous aqueous jelly in the back of the eye. And then behind that is the retina. And then in the middle, well, somewhere in the retina, there's the optic nerve, where all of the nerves from the retina kind of congregate, and the optic nerve travels to your brain. So that's kind of front to back eyeball. I mean, I guess other than outside the cornea, you have what's called the sclera, or the white part of the eye. On top of the sclera, you have a membrane called the conjunctiva. That's pretty much it. That's, it sounds more complicated than it is. So front of the eye, cornea, we'll go cornea, iris, lens, vitreous humor, retina. That's kind of those are the big hits.
Okay, I've not heard many of those words before in my life. So,
it's hard to believe.
Okay, so the I guess a lot of laymen, obviously, their interaction with different parts of the eye might be, using contacts or getting laser eye surgery. Have you done laser eye surgery before?
If I had, then I would want my money back, as I sit here with a pair of glasses on. But
sorry, I don't mean like has it been done to you. I mean, have you
performed laser?
Have you performed it? Yeah.
I have performed various types of laser eye surgery, but I have not done Lasik, which I think is what you're referring to, Lasik or PRK, or any of the corneal refractive procedures, which is what is basically the term for correcting your vision using a laser. I've seen it done a lot, but I've never done it myself.
So you've done, okay, so once again, this is my layman. This is why it's called Learning from a Layman, Ian. I didn't even know there were different types of laser eye surgery. I thought they were all LASIK. You do other types of surgeries to do what?
Yeah, so there's we use lasers a lot in ophthalmology. There's different types of lasers that we use. So there's what we call femtosecond laser, which is used in these refractive procedures. Basically what it does is creates like these micro explosions in space, and Matt might know more about the specifics of how these lasers work. I don't know, I just use them. I'm a layperson. So
we actually had a laser podcast, so Matt did discuss lasers a little bit with us.
That's what I heard, and then I went back to look at it and I couldn't find it. So I guess I just maybe I need some laser vision correction to do that. But these the femtosecond laser creates these kind of micro explosions, and you can use it to create basically cutting into the cornea is typically what it's used for. You can also use it to break up the lens, and so that one you use to create, for LASIK, for instance, use that to create a flap, and then you lift the flap. So you're creating a flap. It's like a partial thickness of the cornea. So the cornea is like a clear tissue. You're creating partial thickness cut, and then you flip up the flap, and then you use a photoablative laser treatment with what's called an excimer laser, and that basically shapes the cornea so that you're bending the light properly to focus on your retina. So you're basically changing the shape of the front of the eye, and then you put the flap back, and then you're done. So that's LASIK. But there's other types of surgery. PRK, you may have heard of. that one is you basically you have to remove the entire epithelium or the very like surface of the cornea, and then you use that ablative treatment I was telling you about to reshape the cornea, and then it just grows back. The epithelium grows back, but that's a little bit more painful. And then, but we use lasers for other stuff too. So we often do something called PRP for patient with diabetic disease in the eye. PRP is panretinal photocoagulation. It's very long term, but basically you use a laser it's an argon laser to burn the parts of the retina that are not really responsible for central vision, and that's for reasons that I guess we can get into if we want to talk about diabetic eye disease, but so I've done that hundreds of times, and then we also use like a YAG laser, which is like correct me here, Matt, it's like
elements.
Crystal. Yeah, exactly. It's like crystal
magic elements.
Sorry, yes, magic. It's like a magical element that it creates also these little explosions in space when you focus these two lasers on each other, and then you can use that to essentially you can either use it to create holes in the iris, which can be useful in some circumstances. There's sometimes a membrane will form on the behind a lens in the eye. Anyway, use it basically to manipulate tissue in the eye without actually going into the eye. So there's a lot of different lasers that we use. It's pretty cool. It's pretty cool stuff.
Wow.
If only I knew as much about how the lasers worked as how to work the lasers.
Well, you can always listen to our podcast.
It's true. I just need to find it, and then I will.
That's yeah. We shamelessly self-plug our own podcast on our podcast all the time. So it's okay.
Might conjecture a couple things that are probably wrong. So I suspect, and I've never dealt with these lasers myself, so I could be way off. But when you talk about femtosecond lasers, you're talking about essentially the amount of time for which it activates, which is a femtosecond, which is not very long. And so what you get is, instead of a beam of light, you kind of get like a light pancake. And that's really good, because if you had a beam of light, it would very quickly burn right through your eyeball, and that would be terrible. Whereas if you have controlled little femtosecond pulses, you can be very precise and actually do stuff to the eye without blinding the person.
Yes. Yes, that sounds about right to me. So the femtosecond laser is used in either like manipulating the cornea, which is that front layer, or you can use it to assist you in cataract surgery as well, in either creating a cataract is basically when the lens, which is behind the iris, gets cloudy, and then we call it a cataract. But yeah, it basically emits these pulses of light, as Matt was saying, duration of a femtosecond range, or quadrillion for the second. So it uses maybe we should ask ChatGPT how it works, and then we can get into more details. But this isn't a laser podcast. Maybe we should just refer back to that one.
Yeah, we need to hit.
But I believe it just it creates, because depending on the wavelength, the intensity, it basically creates these it actually ionizes the material and forms plasma of the tissue. So great amount of energy, but in very controlled bursts.
Okay.
Yeah.
I do the idea of Lasik has always made me uncomfortable. The idea that you just said, and I've heard before, the word flap in your eye, it seems inappropriate and kind of gross.
I can understand that. Yeah. Well, clearly I haven't had it done yet, but that's mostly.
Well, hey, wait till you hear about the natural body processes that you go through every day, starting with the duodenum.
Duodenum.
Is this a reference to another
podcast,
a recent episode?
It is the basics of organs.
Hey, if I can ask on a somewhat serious nature, and I apologize if we're derailing away from the pre-planned questions, but
okay.
Jumping into LASIK, I know that it can be very effective in restoring visual acuity, but I also understand that those effects may not be permanent. Can you talk to what does and doesn't make those kind of corrections last?
Yeah, so part of the issue is that LASIK will change the shape of the cornea, right, to better focus light on the fovea, which is the part of the retina that is responsible for really sharp central vision. Typically it'll work very, very well. But one of the reasons why people might say it fades with time is a concept called presbyopia, or basically your eyes getting old, and that refers to the mechanism. So in the mechanism of the lens in changing shape and the focusing power of the eye, and changing the focusing power of the eye. So when you're a little kid, or anytime, basically people under the age of 40, the lens can change shape. You have muscles that change the shape of the lens, and the lens is flexible. And the lens is the this like crystalline protein structure that sits behind the iris. And so you can change the shape of the lens to look far away and up close. And so when you're looking far away, the lens will kind of flatten out, not bending the light as much. And when you're looking up close, the lens will sort of condense, and it shifts, and it bends the light a little bit more. And so you're able to focus both close up and far away, and your eye can shift back and forth between up close and far away with no difficulty. But after the age of 40, your lens begins starting to undergo these changes, which makes it more rigid. And so you're not actually able to bend or change the shape of the lens anymore. And so that's why people over the age of 40 start needing to use reading glasses, because they can't accommodate. We call it accommodation, when they're changing their focus between near and far. So that is one reason why people might say LASIK doesn't work after a certain age, because there's no great fix for presbyopia other than bifocals or reading glasses. So even if you have LASIK, you might be 20/20 at distance, but then once you get to a certain age, you're going to need reading glasses anyway, and that's true for pretty much everyone. So that's one mechanism. The other thing is, sometimes the shape of the cornea will change. The structure of the cornea is not necessarily as rigid in some people, and so you are changing the shape of the cornea with LASIK, and then it might relax, or there's just various reasons for which it would your treatment would regress, and you would need a touch up or something like that. But typically the treatment effect is fairly durable for most people, like 10, 15, 20 years, until they start getting a little bit presbyopic, we say, or they start needing reading glasses.
Thank you.
Yeah,
that is illuminating.
Mm-hmm.
Nice. Okay, a couple more layman questions for you, Ian. I wear contacts. Obviously, I see you're wearing glasses right now. Are there benefits to wearing glasses over contacts? In particular, one that I believe I've been told before is wearing my contacts, while I'm asleep is a bad idea. Why, and what else am I doing to my eyes when I'm wearing contacts?
Contacts are pretty safe. They're a good solution to correct your we call it refractive error, or your inability to see without glasses. They're a good solution. For some people, yeah, if you're sleeping in them, that's bad, right? You can get bacteria in there. I've seen more than my fair share of corneal ulcers that form, bacterial infections of the cornea that form in people that use their contacts incorrectly, and that can blind you pretty quickly without the proper treatment. So So that's certainly a risk that you don't have with glasses. Some people have dry eyes, and that makes it tough for them to use contacts. I've tried using contacts in the past, and I think my eyes just got too dry, or maybe they're too sensitive. I think when you wear contacts for a while, your corneal sensitivity also tends to decline a little bit as well. You know, you don't really feel them as much, and I don't really know if that has any ill effects, but it's just one effect of wearing contacts chronically. Yeah.
Interesting. Okay.
But there are lots of different types of contacts too, and many of them are medically necessary, and so I think they're very very useful technology.
You mentioned that as you age, your eye changes. Do your eyes generally, as you get older, do you have more issues with dry eyes as you age?
Absolutely. Yeah. That's just
Why is that?
Well, I think there are like two mechanisms by which that happens. One is, you're not maybe producing enough tears, and the other is that they're just drying out more quickly. So it's kind of like, if you're in a drier environment, then your eyes are going to dry out faster, and then if you're not producing enough tears, your eyes are going to dry out faster. And typically, as you age, I think your for whatever reason, your lacrimal glands, which produce the tears, are not as active, or and then you also have oil glands in your eyes, that in your eyelids, sorry, that produce what we call meibum. They're meibomian glands, and they produce this oil. It's very important to coat the surface of the eyes and make your tears stay on the surface of the eyes better. And this, people are like, oh yeah, whatever, dry eyes, no big deal. But some people are really profoundly affected by this, and you can actually have really, really poor vision if your eyes are too dry. The tear film is very, very important. So for whatever reason, those glands can get blocked, especially as you age. And so that can be an issue. But
So
it's for the same reason everything kind of breaks down as you age, I guess.
So crying more is not the solution as you age?
Ironically enough, people with dry eyes complain of crying a lot, tearing, right? It's like, oh, why, like, how are my eyes dry? I'm tearing up all the time, and the body's trying to compensate for not having a good tear film, and so it's producing all these extra tears that are running down the face, but they're not really helping to alleviate the dryness. So. Unfortunately, no. Tragedy is not the solution.
So no Shakespearean tragedies are not the prescription for dry eyes.
Yeah, I mean, no, we don't just say, go home, watch sad movies, read sad books, think of sad. It's like when your eyes are feeling dry, just try and think of the worst and most depressing thought you can.
It's like the opposite of Peter Pan, right? Like, instead of focusing on the happy thought, it's
think of a miserable thought. Yeah, that's what we say. Any miserable little thought will do.
The song not quite as catchy, but
yeah. Well, if only they could have, like, dismal, maybe that would work better, at least in terms of the syllables.
Yeah, well, I can cry, I can cry, I can cry.
Yeah.
It seems.
We could do this. Yeah, we could do a little educational video. We could show it to our patients in the clinic. Yeah.
Seems the way to go. Okay, well, you're welcome. Okay, rubbing my eyes. I've heard that rubbing your eyes can have bad effects. Is that true, or is that a wives' tale?
It depends is the answer. So you may have seen that viral video going around of like the people with like the MRI. Maybe you didn't see that one, but it was like someone was taking MRI while they rubbed the eyes, and it was basically retropulsing the globe into the orbit. So you're just like pushing the eye back, and it looked gross, and people were like, oh my gosh, like, look what you're doing to your eyes. But like in reality, we humans rub their eyes all the time, and they have been for as long as humans have been around. And most of the time, your eye can be pretty tough. There is one circumstance where that can be a problem if you're really vigorously rubbing them a lot. And typically people don't do that, but some people with like severe allergies might do that. and or with behavioral developmental issues, that can be a problem. And people with what's called keratoconus. Keratoconus is a condition where for whatever reason, the structure of the cornea is not as rigid as it should be. And so as you, it usually starts around, teenage years, and it progresses. So your eye, becomes your cornea becomes more conical, and rubbing your eyes accelerates that process as well. So if you have keratoconus, then you absolutely should not be rubbing your eyes as well. And that, even in people who have okay corneas, if you're really doing it so like, a lot, but for the vast majority of people, it's not really a problem. It's probably not the best thing to do, but you might be introducing bacteria in there and stuff, more likely to get conjunctivitis and that kind of thing. But it's not like I wouldn't go on like a public health tour to warn about the danger of eye rubbing. I mean, we've got plenty of other issues going on, trust me.
Right.
Like diabetes, for instance. I think, if we gave people more instruction about not getting diabetes, I think that would probably go further.
Useful. I think that would be probably a better use of everyone's time.
Exactly. Maybe,
okay.
People like to eat sugar, so.
That's what I've heard.
Yeah.
I might have sugar literally right there.
Just for you to consume, huh?
Yeah, I work in front of the computer all day and I have to have it like at arm's distance. I'm not diabetic though yet, so I'm okay, right?
Yeah, well, for now, yeah.
I like how you use the word yet. Yeah.
Yet being the operative word, yes.
I'm trying to be better.
You also haven't died yet. Imagine that.
Okay. Let's focus less on my shortcomings and more on Ian's knowledge of. This is my podcast. Okay. Let's see. Okay. I've been to the optometrist a fair amount, and they have all these different tests to like test the health of my eyes, and one of them is like I stare in front of me, and they have like little like dots, like little that I have to like, and I've got like a little clicker. And
wow.
are you familiar with this one at all?
Yeah. I'm just surprised that they had you do it. I mean, like.
Oh, I've had to do it a lot.
Oh, and are they concerned that you have glaucoma or something?
I have no idea. They're probably just milking my insurance dry, and
that's probably true because there's really no indication, at least as far as I'm aware. I haven't looked at your eyes, but unless you have, unless there's concern for glaucoma, there's very little reason to do a visual. That's called a visual field test. So
okay,
it's typically, there's different kinds, but we use the Humphrey visual field, and the company that makes it actually, doesn't tell you how they calculate. The various metrics that it spits out at the end. It's proprietary, but in essence, it tests your peripheral vision. So
right.
So you're looking straight ahead, and then you're clicking when you see the light, right? You don't want to be moving your eye, and people hate the test because it's it's like weirdly stressful.
It is. Yeah, it's like I'm taking a test. Like I'm back in college and I'm taking a test, and I feel like I'm making up the dots sometimes. It's like, did I see something or did I not? Because it's peripheral vision.
It's like you're taking a final exam and you'll never find out what the results were.
Exactly.
You'll never know if which answers were correct and which weren't.
Right. Yeah.
But yeah, that's the test for. So there's two reasons to get that. The first is glaucoma. So glaucoma is a chronic disease of the optic nerve, which is a degenerative disease of the optic nerve, and it's associated with high pressure of the eye. And so, so that's another test that everyone will do. The eye doctor will do in the office, is to test your eye pressure. And if it's high, then it's more, it's potentially a concern for glaucoma. But you lose your peripheral vision, but you don't even notice. So that's why they do that test, is to pick up any peripheral vision loss that you haven't really even noticed. And then the other thing that they do it for is like strokes or brain lesions, which can cause sometimes characteristic patterns of visual field loss. So if you have a tumor, let's say on the right side of the brain, in various spots on the right side of the brain, you can have left-sided vision loss in both eyes. And so you can kind of see, almost like it's like both in both. Some people will be like, oh, there's a problem with my left eye, but the answer is it's actually there's a problem with both eyes in the left, in like the left-sided visual field. So, or if you have a tumor that's compressing the pituitary gland, that causes what we call bitemporal hemianopsia, which is you lose your peripheral vision on both sides, preserved nasally, but in the temporal field, which is off to the sides, you lose vision. So basically, if back before MRI and CT was readily available, these were very useful tests to get to kind of to localize some of these brain lesions. But it's kind of cool when you pick it up. It's a little bit of detective work.
Interesting. Yeah. Well, I so far have not had a stroke or glaucoma or any of those things.
Yeah. Good.
So does that mean I passed? That means I'm passing the test.
So far. Yeah. Just like you don't have diabetes yet.
Right. Okay, but what I have found is like there I've been told at least there are like blind spots in your vision field, right? Like
it's only if you're looking at the laser.
Yeah, I had this laser pointer and I just kept it trained on one. No, not
disclaimer, do not be like Carl.
You're staring at the sun.
No. There is a part of your visual field that is just a normal blind spot, right? And your brain essentially paints over it. Am I getting this more or less right?
Yeah, that's correct. And it's called the physiologic blind spot, and that's where the optic nerve is in the eye, in the retina. So the optic nerve is, as I said before, is where all of the nerves and the photoreceptors, the photoreceptors are all over the retina, and they receive the visual input, and then they transmit those to the nerves, and the nerves all travel into the optic nerve. It's like the highway, like all of the, they're all moving out of the city of the retina into the highway of the optic nerve. And right at that highway, there's so many nerves congregated there that there are no photoreceptors. So you're not actually using that space in the back of the eye to see anything. That's just where it's being transmitted. So, it's that's what the blind spot corresponds to.
Okay. Yeah. Nice. All right. So one of the things that they ask me a lot when I go to the eye doctor is whether or not I've got a bunch like floaters or flashers.
Mm-hmm.
What are those?
So flashing lights and floaters can be associated with retinal detachment or retinal tears or retinal holes, and so that's why they ask that. If you have traction on the retina, so as I mentioned before, you have this vitreous humor in the back of the eye, and that it's not just like a jelly that sits in there. There's like a membrane associated with it, and that membrane can be adherent to the retina. The retina is like the wallpaper on the back of the eye, and that's where all your nerves are. And so when the vitreous, especially as you age, the vitreous will start to liquefy, and as it does, it sort of contracts. And so there's a membrane around the vitreous that is adherent to the retina at certain locations, and as it contracts, it can kind of tug on the retina, and that can cause flashes of light because you're stimulating the photoreceptors in there, and and then they cause these flashes of light. And around age 50, 55, 60, a lot of people will have what's called a posterior vitreous detachment, which is when the vitreous kind of pulls away from the back of the eye. And when that happens, there's like a 10 to 15% chance that it causes a tear on the retina. And so but either way, you'll have a lot of new floaters and a lot of new, and sometimes flashes of light when that happens. And usually it's fine. Usually it's no big deal. But when that happens, it can cause a retinal detachment. So that's why they ask you that, to kind of, if you're like, oh yeah, I had a bunch of flashes of light and now I have 1,000 new floaters, then they're going to be on the lookout for a retinal detachment.
Okay, so that's the flashers. The floaters are, you said those are what are those?
So the floaters are condensations, like protein condensations in the vitreous. So like they are actually, everyone has floaters. If you look right now, if you look at if you look at a white surface and you have, especially they're especially evident when you're like looking at the sky, because when it's in bright light conditions, when you're looking at like a solid surface, you'll start to notice them. Or if you're reading, you might notice them kind of just floating around. And generally, they're not too visually significant. Some people have very large and annoying floaters that really bother them. But in most cases, not a huge deal. But they're just basically little pieces of protein that are floating around in the vitreous. So as you move your eye, they kind of move with it.
Is there anything you can do to get rid of them?
No, most of the time you just start to, if you have like, new ones or whatever, most of the time your brain kind of gets used to them and you just ignore them. But if they're really bothering you, then you can have retina surgery, basically a vitrectomy, where they go in, they put some trocars, they call them, in the sides of the eye, and they use a cutter. Where basically they extract the fluid or the vitreous, and then they fill it with just saline solution. And that's, I wouldn't personally opt for that solution unless they were really, really bothering you. But people do it, and they call it a floaterectomy.
Wow, that sounds radical.
Yeah, I mean it's not covered by insurance. It's like it's kind of like an very elective procedure, and it's a little controversial, but people will do it. Yeah.
Interesting. Okay. All right. Well, I won't be doing that, but once again, you just said the word cutter around an eye. So anything that has to do with cutting my eye, not a fan of.
Right. Well, yeah, that's only because the vitreous is so sticky. You have to cut it at the same time as extracting it. So you don't. Anyway, it's
nobody wants
I shouldn't have said that. And thanks for bringing that up. I'll try to police my language.
Yeah, you're making me slightly queasy. I appreciate if we could just use like fluffy words. Yeah.
Yeah, not cutting. No, massaging. You massage.
Massaging with the edge of a blade. Yes.
Exactly,
Okay. I learned probably before the Death Cab for Cutie song, and maybe you're not familiar with this Death Cab for Cutie song, but the beginning of it is when I see you, I really see you upside down. It's a good one if you're a Death Cab for Cutie fan. If not, it's still a good one.
Okay.
It's not.
I saw them in concert once.
Okay, there we go.
I don't know if I'd qualify as a fan, but yeah, I like some of their stuff.
Yeah. Okay. So are they correct? When I see you, I mean, this is something everyone has heard, and the light comes in. What am I actually seeing you upside down?
I mean, it just depends on what you mean, right? It depends on your frame of reference, right? In terms of relativity, are we stationary? Are we moving through space thousands of miles an hour? So, I mean, I think what they're referring to is the fact that when light is projected onto the retina, what the image is perceived upside down, or the image is transmitted upside down, but then it's perceived right side up, right? Your brain flips it right side up, but the top of your retina sees the bottom of the vision. The bottom of the retina is responsible for the top of the vision. Right is left, and left is right. And to make it even more confusing, when we examine the eye, it flips everything too. So everything we look at in the eye is upside down and backwards. So the same way light is kind of is going in. So, but yeah. So yes and no.
Got it. Right. Perfect.
To answer your question succinctly, yes and no.
Yeah, I love doctors that answer yes and no. It's my favorite.
Yeah. So is this the what should I do? Well,
you could do this, or you could not do it.
Exactly.
Okay. You already talked about blindness. That's something that really interests me. I don't have a lot of experience with interacting with the blind community, but there are, like, what I've understood is that, like what you said, that there are gradients for blindness, and so the people that we traditionally identify with being blind, are they like, is their retina not attached? Do they not? I mean, because there is a level of blindness where there's just nothing going on between the eye and the brain, right?
Mm-hmm. Yeah. So there are many causes of blindness, and so it really depends on the cause and the profoundness. The profoundness of the blindness depends on the cause and the severity of the pathology, right? So if you I can list a few reasons. Retinal detachment, that will cause blindness. But even a detached retina can still have some vision. You can still sometimes perceive light or hand motion. Typically diseases of the retina will not. It's rare for diseases of the retina to cause no light perception vision. Yeah, I'll say that it's rare, which is the most profound level of vision loss, because even people who are considered blind. So legal blindness is considered to be 2200 or worse. And so that's when you at 20 feet can see what an average person can see at 200 feet. And so that's considered legally blind. So anything worse than that is legally blind, but 2200 is a lot better than light perception. You can still read large print. You could still, make out people coming down the hallway. You could probably still walk, most of the time. But if you're light perception, all you can see is light. If you're hand motion, you can be like, I know the hand is moving up and down or left and right, count fingers, but so there's varying degrees of blindness. But diseases like glaucoma, end stage glaucoma, that can often lead to no light perception vision, because the optic is no longer transmitting any visual information to the brain.
And that's the point. So I guess with no light perception blindness, there's no treatment that an ophthalmologist can do that will restore vision to any meaningful level.
That's large. By and large, that's correct. Yeah. Once you're no light perception, there's not much coming back. If let's say your light perception or your hand motion and you have a dense cataract, you can do cataract surgery. And assuming there's nothing else going on in the eye, you get the cataract out, you put an artificial lens in that could be 20/20, so okay. So it really does depend on the cause of blindness. But if you're hand motion or light perception and you have end stage glaucoma, then that's an irreversible cause of blindness, and so there's nothing you can do about that. Retinal detachment, if it's detached all the way, you can reattach it, but you may go from like hand motion to at best 2200 vision. 2100 vision. You're not going to get back once the retina is detached. It's become pretty damaged, and so even by reattaching it, you preserve the anatomy of the eye, and you're less likely to have problems with the appearance of the eye, but your vision is not going to go back to the way it was.
Okay.
Yeah, a lot of different causes of blindness, and different degrees of blindness. It's a pretty broad spectrum.
Right. Okay. And is there anything that we can, the layman needs to do or know about eye health, as far as what they can do to help prevent later diseases later? I mean, you mentioned, like, obviously don't become diabetic. If you're not a type 1 diabetic, don't become a type 2 diabetic.
Yes.
But other than that, what insights can you give the layman to help them with their eye health?
There's not a ton to be done in terms of preventative care for the eye. Systemic conditions, right? Don't sleep in your contacts. don't get diabetes, and if you do, keep your blood sugar under control. Treat your high blood pressure. You can have strokes to the brain the same way you can have a stroke to the eye. Or an occlusion of an artery or a vein that can cause blindness.
What about wearing sunglasses outside? Is that actually beneficial long term to eye health?
Yeah, that's a good idea. If you are in the sun a lot and without sunglasses, you can start developing cataracts more quickly, and you can also develop what's called a pterygium, which is like an overgrowth of the conjunctiva, or the membrane over the white part of the eye that can kind of grow onto the cornea. And we see that a lot. And so there are definitely drawbacks to not using sunglasses if you're in the sun a lot. For most people, for most people who work indoors most of the time, it's not a huge deal. But it's not a bad idea to use sunglasses for sure.
Okay, so then on the
flossing.
same flossing, yes, you're an eye dentist.
Yeah,
what
yes.
is the equivalent of flossing? I mean, do I like scrape my eye with a Q-tip, or I mean, what's?
I wouldn't recommend that, but you can do warm compresses, artificial tears. That's kind of the catch-all treatment for discomfort. But for people who don't have dry eyes or experience issues with that, then it's like not a huge deal.
Okay. But this is where we get back to the "I Can Cry" song, right?
And yeah, exactly. Just watch a lot of sad movies, and it's just like if you immerse yourself in tragedy, then generally speaking, it's great for your ocular health.
Okay, all right.
But no, I mean, I think once you're of a certain age, after age 50 or so, probably, you should probably get checked out regularly for to make sure you don't have glaucoma, make sure you're not if you're developing a cataract, you'll start to notice. That's the indication for taking it out, is that your vision's blurry and you're not correcting with glasses. And so you'll know the cataracts aren't really dangerous. But yeah, flashes and floaters, if you start having those, go to the emergency room, because you could develop a retinal detachment. Sometimes it starts small, you just see flashes and floaters, and then it progresses, and then your retina is detached. And if you get it fixed before that happens, then you have a good chance of saving your eyesight. But if once it detaches, then you're in bad shape. So
okay, one last off the wall question before we can wrap here in, and I don't think they teach you this in medical school, but maybe they do. Animal eyes. How familiar are you with animal eyes, and how similar, like a lot of people out there listening to us right now have a dog or a cat, maybe a guinea pig?
And they're all thinking, I could have those eyes.
Have you seen Will Smith's 7 Pounds? Can we use the eyes of animals to put? The actual question is, how similar are animal eyes to human eyes?
Can we transplant animal eyes into humans? Is that what you're asking?
I was moving that way, but I was trying to move away from the slapstick silliness. But yes, I'll take the answer to that as well.
As much as I would love to say yes, the answer is no. But animals' eyes are pretty analogous. They have all the same structures, more or less. Mice, I've dissected mice eyes for various research projects, and they have their lens actually fills the entire eye, which is interesting. So the lens is much, much bigger compared to the eye than ours. And they have, let's see, I think, so, I think dogs, for instance, have a lower visual acuity, estimated to be around 20/70, whereas humans, see 20/20, and then they have limited color vision. They have better night vision. They have more rods than cones. So rods are the type of photoreceptor that can perceive light and movement, especially in dim lighting conditions. And then there's cats and dogs have, and some other animals, they have a special layer of tissue called the tapetum lucidum that reflects light back to the retina. And so that's what you notice if you ever see like a cat in darkness, their eyes are shining, right? Or like a leopard, whatever, like kind of the creepy eyes looking at you from the darkness. That's because of that extra reflective layer they have in the retina that helps to augment their night vision. So humans' eyes do not have that, but and then often the way that eyes are set, horses have really great peripheral vision. but I think they probably don't have as good binocular vision.
Yeah.
Not using their eyes together too often, but yeah. Anyway, eyes. There's a whole world of eyes out there, Carl.
That's true.
It would take another podcast episode to really delve into the answers to this question.
Come back for our next podcast, the basics of animal eyes.
Yeah, you need a veterinary ophthalmologist, and
is that a thing?
They do exist. I think.
Oh wow.
They matter.
They do cataract surgery.
Oh, all right, nice.
Yeah.
Okay. Well, that's quite the way to end the podcast there.
I know, that's pretty bad, but there you go.
Well, I appreciate you coming on and sharing your knowledge. And at this point, I think we can grade the podcast a success, at least from my side, Ian. So you can still claim family relation, or wait, that's.
Well, you won't disown me, I guess.
I won't disown you, but whether or not you disown me, that's up to you.
We'll see. I'll probably listen to the final results, and given how hard it is to listen to your own voice in any recording, this may be the last time you hear from me on a platform like this.
Yeah. Well, you did a great job, and we appreciate all of your insights and knowledge, and the ability that we had to silence Tim in the end was truly meaningful.
Yeah, that was the highlight.
All right. Well, thanks, and we'll see you guys back next podcast.